Yep.
Great. So thanks everyone for coming. Our first speaker is Nicola Burns, who is joining us online. Feel free to start sharing your screen and she'll speak for 12 minutes and then we'll have 5 minutes for questions.
Just can everyone see that okay? And okay, I'll just put to. So thank you for inviting me along today. It's great to be able to contribute to the session. And the presentation that I'm giving today is something that is I've been working with my colleagues, Carolina Follis at Lancaster University and Luca Follis at University of Sussex over a number of years. And so our work really came out of a project, our ongoing work, from 2019 to 2021, and it was called Doctors Within Borders. It was funded by the Wellbeing Trust, and it was really to facilitate networking with researchers, practitioners, and advocates in the UK and internationally involved in the provision of healthcare for migrants, refugees, and other displaced people. And we called the project Doctors Within Borders, riffing consciously off of the Doctors Without Borders. And our reason for that was that over a number of decades in the humanitarian movement, we've indeed seen growing numbers of physicians crossing international borders to care for the world's most disadvantaged populations. But our premise was that actually the vast majority of healthcare practitioners do not work without borders, but rather within borders. They practice medicine in domestic settings where healthcare is channeled through national systems that are designed to treat settled populations of citizens and permanent residents. However, in those domestic settings and without travelling overseas, practitioners are increasingly caring for people who are on the move, be they refugees, migrants, or other mobile populations. And they may present with health problems associated with displacement, poverty, and also that they may lack regular legal status and or a permanent address, and that these things complicate access to care. So what we wanted to do in our work was really to start to think about mapping these challenges, thinking about how these challenges are being addressed within contemporary healthcare systems, both at a practical level, also at a systemic level, and as an activist cause in light of the fact that health is a human right. And this was very much a normative principle that guides our work. And so the first sort of conceptual idea that we came to was that healthcare systems are by and large designed to be fixed in place, to be clearly bounded within the nation state container, and to serve a settled population. So we would argue that health systems have a sedentary bias. So what do I mean by that? Well, really, we're working from the idea that really sedentarist metaphysics is embedded in language and social practice, and that these actively territorialise our framing of cultural and national identities. So that's quite a mouthful. What does that mean? Well, in a way, what we're talking about is that this mobilises a view of the territorial displacement as exceptional. It sees movement as exceptional and outside the natural order of things, rather than a fact that about the socio-political context in which people and institutions live and must be responsive to. So what does that mean for health and healthcare? We would argue that it means that for the patient that is on the move, especially unsettled or willingly or unwillingly mobile, is seen as an aberration. That this patient will, in other words, seem to require special arrangements outside of frameworks. And those arrangements may require particular resources, may be deprioritised in conditions that are already hostile to the displaced. And our second premise was that the mobilities paradigm in the social sciences would offer a really useful analytical and methodological tools to come to grips with some of these tensions between sedentary healthcare systems and mobile populations. And so mobilities approaches engage with the actual physical movement of people, objects, data, ideas. And it's also about the way in which mobilities can look across scales. It can go from the cellular level to the body, through to local communities and the global. And this in part has been about the collapsing of sort of disciplinary boundaries, thinking about issues of inequality, power, geography, and anthropology, thinking about discourses and representations, something that is so important when we talk about the rights of people seeking asylum in the present context. So we know from the social determinants of health model, from a health research perspective, that social and political contexts have an impact on people's health and well-being. And when those contexts are characterised by transience, impermanence, disrupted community ties, and the necessity of risky journeys via unsafe means, this ends up exerting a toll on people's health. And care and treatment in such circumstances are often not available. So what we think we can learn from a mobilities approach is this sort of idea of a moving of moving in mobile bodies, the facilities, expertise, pharmaceuticals, data lends itself to an analysis through the lens of mobility by applying questions of who and what moves, in which direction, and who and what stays static. And we can think about this in terms of the politics of mobility and the ways in which actually not everyone has equal access to movement. And indeed, the immobilities are also about power structures. So just to try and give a little bit of a flavour of how we were sort of thinking through some of these issues, we were thinking about the fact that actually this sort of notion of health as as an outcome of structural factors, and thinking through issues of poverty, etc., but also thinking through legal entitlements to health and how access to healthcare systems may be a human right, but this is very much mediated around citizenship, bordering practices in healthcare. And you'll see a couple of these little graphics that were created for us by the illustrator Jack Prof through one of our project outputs. So one of the things that we feel is really important is actually we need to shift our focus from just looking at the lived experience, which of course is hugely important, but thinking about structures, the infrastructures that shape people's experiences of trying to navigate health systems in the everyday. And so we think that's about the movement from law, how that feeds into policy around healthcare, but also around border forces, as I'll go on to discuss. So if we take the idea of the hostile environment, we can see that through health systems, actually, we can see the everyday ways in which borders are created, not just through the hard border at the territory level at crossing points of borders, but actually the ways in which health, along with housing, employment, are implicated in everyday bordering. And so we can see the development of the hostile environment through, I have a picture here of the 2013 document, Sustaining Services, Ensuring Fairness, where the government begins its plan to limit access to health for migrants and people in the asylum system who have had their cases refused. And we can see this in the expression last year of the image of BB Stockholm, the barge, that in fact created health conditions that meant that it was completely unlivable. And so we start to think about the ways in which actually how is the health system implicated in these everyday bordering practices, but also what are the implications of this on healthcare systems and those that work in those healthcare systems as they have to try and navigate these systems that may run counter to their ethical beliefs. Never mind the problems that we know exist for people trying to access resources. And so one of the things that we explore is the notion of health injustice and bordering, and the ways in which these bordering efforts are continued. I'm not sure if this is going to play because I didn't get a chance to check it out, so I'll maybe just move on if that's okay, and if we have time I can give it an attempt. So, okay, so one of the things that's really important about exploring healthcare systems is also thinking about digital infrastructures, the ways in which actually our health systems are implicated and rely on these digital health innovations. And we can think about the ways in which telehealth innovations look to greater levels of data integration. And that actually raises lots of questions in relation to health. For example, the digital divide. Do people have access to information about healthcare systems versus digital inclusion? But also questions that are really important from a perspective of thinking about Home Office involvement around privacy and surveillance of data, but also within the actual interaction between healthcare providers and their patients, how important that very personal interaction can be in terms of building trust and rapport, and what that then means when people are worrying about digital infrastructures impinging on that. And we can see that this really links to a lot of the issues that have been discussed around everyday bordering practices within the field of health. But it also, we would argue, poses new questions around the political economic value of health data sets. What does it mean in terms of the training of artificial intelligence? But it's also political too. It's about border policing. And I'm sure some of you will be aware of the move for Palantir to be a provider of healthcare digital infrastructures and concerns that have been raised around that. So we feel that these issues are very, very pertinent and real to the everydayness of the GP consultation, for example. And so we can see how these health injustices actually work through, and we got, unfortunately, through the pandemic, it really revealed that the ways in which actually sedentary health systems are in fact absolutely reliant upon the mobility of capital, data, humans, supplies, resources, and that actually is quite unequal and uneven, that some things move, some things do not. look at the rollout of the vaccine globally as an example. We can also see that this had a very disproportionate impact on the health of people who were precarious, people on the move. So just to sort of bring the conversation to a close, for Mimi Scheller, one of the writers in the mobilities field, for her, mobility justice moves beyond sedentarist theories of justice, and it works within an egalitarian framework, really concerned with fairness, equity, and inclusion across multiple scales and sites of interaction. It's a mobile assemblage of contingent subjects, enacted contexts, and fleeting moments of practice of political engagement. So how do we think about health in these terms? And I think what I would say is that it's really about exploring very much the ways in which the reproduction of health inequalities in our healthcare system is not limited just to the ebb and flow of pharmaceuticals, medical equipment, but it also relates to these state practices in the pursuit of an exclusionary health system. And I guess in a way, it really reminded me of, in many senses, the Alma Ata Declaration through to the Astana Declaration in 2018, and aligning very much with that social justice aspect of health, and understanding that actually the human right to be healthy is a sort of social foundation in which so many other discussions around justice must take account of. Thank you.
Thanks so much, Nikki. I think we could take one question. Billy, were there any questions online?
Hello. If you haven't got any questions, may I ask one? I've been trying to raise my hand, but unfortunately I can't get the hand raising button to work.
Sorry, who's that?
It's Beverly Bergman.
Hi, Beverly.
Hi. So if there aren't any other questions, if I may ask one, it's not just the refugee, displaced persons, asylum seeker population that we need to worry about. Even much closer to home, this is an issue. And I represent the military population, and very often we've seen maybe a military family have been living in the south of England. The serving person is posted up to Scotland. The non-serving spouse is perhaps on a waiting list, maybe a wife who's awaiting a gynae appointment for endometriosis, gets posted up here and finds herself bumped back down to the bottom of the waiting list on a fresh referral. So that's an issue. And another issue is university students, and a young relative of mine is a student at one university and lives in a completely different area. And during the vacation, whilst at home, needed healthcare. But the local GP practice was very reluctant to see her because she was registered with the university practice. And it almost got to the stage of her parents having to drive her back to the university so that she could go to see the university practice. So, I mean, there are real issues about mobility in healthcare. And also, if you don't have an address, so again, going back to the military example, if you've just left the forces and you haven't settled into a new address, it's very difficult to do anything. And that's not just healthcare. You can't register for a bank account. There are lots of things you can't do if you haven't got and if you can't prove a fixed address.
If I could just respond, if that's okay, I would absolutely agree with you, Beverly, and I think that's our sort of wider point that we focused on for the purposes of this talk. I focused on people who are seeking asylum, but I agree. I think that when you start looking at it, you realise that actually at lots of different spatial scales, we can see that many groups are actually, there is this assumption, and as you say, you know, moving from NHS England to NHS Scotland, you know, there's not a smooth transition there, and actually who is it that that faces that? Well, it's the individual in their healthcare. So I would absolutely agree with you. One of the groups that we worked with was a community health practice in England, and they were talking about their work with the populations of destitute and homeless people who weren't necessarily people seeking asylum, but again, all the issues are raised. And we also know that unfortunately many people, when they leave military service, are very much at risk of this destitution and homelessness. So you're absolutely, I would absolutely agree with your point, and thank you for raising that.
Thank you.
Thanks so much, Nikki. Another round of applause. Okay, and our next speaker is Kirstin Mitchell, who will be presenting on at school.
Thank you, Caroline. Hi, everyone. So my name is Kirstin Mitchell. I'm just going to be giving you a little bit of an introduction to the Equally Safe at School trial on behalf of the Equally Safe team. So I just want to start by looking at the current context in terms of gender-based violence and secondary schools. So many of you will have heard of the Everyone's Invited website. So it was launched in 2022, and it gave survivors of sexual assault a chance to share their stories of sexual assault at school anonymously. To date, there's well over 50,000 contributions, and most schools in the UK are named on that website. It was pretty impactful in the sense that it forced policymakers such as Ofsted, the government, to sort of sit up and recognise that this was a problem that was being ignored, and the sheer scale of the issue came to many people's attention. At the same time, unfortunately, many of you will have also heard of Andrew Tate, and schools are very much currently having to deal with the fallout, if you like, from his misogynistic views on impressionable young men. Because of the sheer size of his following, he actually has this singular influence, and there's even sort of symbols and terminology that follow him. But it's really, he's also a symptom of our exposure, all of our exposure actually, to algorithms of social media that sort of channel these views, and in this case, amplify unequal attitudes and misogyny in society. And some of the teachers I've been talking to while recruiting for Equally Safe at School have also been telling me about the impact of the direct impact of the pandemic, and a whole cohort of students who've actually been at school, at home, and maybe have had less influence of school over those 2 years. And so when they come from homes where unequal attitudes are espoused, then they're sort of taking them, they're more sort of susceptible to them. So this is the kind of context for the Equally Safe at School trial. You would think with this kind of sheer scale of problem being identified that we would have some data. In fact, there is very little good data for UK schools. As part of an earlier phase of the Equally Safe project, we actually did publish a paper on the pilot schools. It was just 3 schools, but we did highlight that 2/3 of secondary school students report one of 17 different sexual harassment behaviours in the last 3 months at school. So that's just a really common experience for students. In the trial, we've kind of narrowed our main outcome measure down to 5 key behaviours, and whoops, that's having a life of its own. We estimated actually in our sample size calculation that would be about a third reporting these. And in fact, looking at our initial baseline, we're having an initial look at the baseline data right now, and it is indeed about a third of students reporting one or more sexual harassment behaviours. So why do schools matter? Well, the roots of male violence against women begin very early. They're rooted in unequal gender norms, harmful attitudes, discrimination, gendered bullying, sexual harassment and assault. And patriarchal and unequal attitudes in society shape the norms that then excuse and enable GBV. Schools are really key sites in which these norms are established. They may be tolerated or condoned by the broader school culture. Secondary schools are also obviously full of adolescents, and it's in adolescence that perpetration and victimization of GBV first begins. And we know also that the perpetration of sexually coercive behaviours in adolescence is a key risk factor for perpetration in later life. So it's something that affects all students, regardless of sexuality or relationship status. And we also know that there's a continuum of behaviours which begins with sexual jokes or gestures or looks, but the students who experience those, and they're often passed off as banter, are more likely to experience then the more serious things like sexual coercion. So the roots of what we're now doing as a randomized controlled trial actually go way back to 2016. And so it was way before the Everyone's Invited website. And it began with a conversation between myself and Catherine Dawson at Rape Crisis. And at that time, they were keen to develop a whole school approach to gender-based violence. And we got together with our team at University of Glasgow as the research partner. It's really been a really fruitful, positive collaboration of the third sector organisation with a research team. When we first started out on this and started talking to schools, they recognised that this was an important problem. At that time, they just felt it wasn't a priority compared to some of the other things they were dealing with. A lot has changed since then, and now, you know, we've had really not much trouble at all recruiting schools who want to take part in the trial, because they've really seen an increase and a worsening in all these behaviours, and obviously there's much more awareness of it as well. So it began with co-design with students and staff in schools. We ran a pilot in 3 schools. Rape Crisis then developed this web-based intervention. It's school-led, it's whole school. I'll come on to it in a second. And that was launched in August 2021, and schools began signing up for it. For us, it was just really, good timing. We were then in a good position to apply to the National Institute of Health Research for funding for a full trial. I'm not going to show you this video, but we did quite a lot as part of the pilot phase. And one thing we did do was to produce this animated video. If you'd like to look at it, you can, oh, it's starting. Oh my goodness, this has got a real life of its own. So if you would like to look at that video, you can go on the Equally Safe at School website and have a wee look. Okay, but basically it was lots of qualitative work that went into this animated video. It's now part of the teaching tool in the intervention. Another thing that we did that is also now a teaching tool and used in training with staff is to produce a systems map of the reporting and prevention of sexual harassment in schools. Don't worry, you're not expected to be able to read any of this. It just gives you an idea of how things are interconnected. And in fact, we saw that there were 4 key themes in the map that related to whether or the extent to which these problems were being picked up and responded to well in schools. And that was knowledge and confidence, whether the school set it as a priority, whether the staff and students trusted the reporting system, and the extent to which there was good communication between the various actors involved in handling incidents while maintaining confidentiality and safeguarding. I'm not going to go into the details of the map, but this is just the knowledge and confidence subcomponent of the map, if you like, just to see what one of the sections looks like. And this is just a quote from a staff member, really illustrating the theme of communication and safeguarding, and this idea that when incidents, a teacher would recognise an incident of sexual harassment, triage it, but then never hear back what happened, and that then undermined trust in the reporting system. And you can see this is a feedback loop within the system where because the topics are because the incidents are not fed back by the staff who report them, it leads to an undermining of understanding of the system and then a reluctance to support. So we're discussing all these kind of feedback loops with staff. This whole map is called a causal loop diagram, and one of the things that these system maps are good for is identifying opportunities to for change. And these are some of the things that came out of the map that are actually built into the equally safe intervention. So the staff training, there's lots of different strategies to build trust, to build awareness, and to improve communication. And we talk to the schools about how equally safe works when they prioritise sexual harassment. So this is what the equally safe intervention looks like. There's self-assessment, so it's very much based on the schools having data about their schools from staff and students that they can work on. Training for teachers, and that's an online component for all and an enhanced training for some. Setting up a student-led action group, and they take forward the learning from the self-assessment and follow up on really direct actions that are relevant to their school. Embedding gender equality into the curriculum, and then ongoing monitoring and evaluation. So these are the key components for the schools, but how they do this is all quite flexible. It's all led by the schools, and we are there just to support them. As I said before, it's just all based on this website. So this is what the external facing page looks like. The schools log in, they have their own account, and they have a dashboard where they can update all of their activities. And these are what the website looks like, the buttons, that they can then enter their data and their progress. So on to the trial. This is our theory of change for the equally safe intervention. There's a lot here. So just to walk you through it, at the top row, we've got our understanding of the problem. The middle row is the intervention itself, and you can see the components of the intervention that I've just shown you are there in the middle. And on either side is our theory of change for how we think the intervention is going to bring about change. Underneath that, you've got a few factors that explain when equally safe works well, the conditions for success, if you like, and these come directly from our pilot phase. So the school management need to believe it's important. They have to be able to devote sufficient time and resources. It very much hinges on the leading teacher. As with all school interventions, if your lead teacher goes off on long-term sick leave, it can be a real critical time for the intervention. And we saw from the map earlier that the importance of staff training and the importance of integrating activities within school processes. And then the bottom row is for our trial and is the outcomes that we're going to measure. And our primary outcome is reduced experience of sexual harassment reported by students in the last 2 months. I won't run through all these. You'll be asleep by the time I do. But these are our research questions. And we're basically looking at can equally safe reduce sexual harassment reported by students? Can it change the way schools respond to the GBV? Is there a differential impact the way equally safe works according to student age, gender, socioeconomic status? The process evaluation, is it delivered with good fidelity and reach? Is it acceptable? We need to look at what happens in the control schools, make sure there's not contamination, because there are obviously a lot of schools who are itching to be addressing these issues. And yeah, what other resources and assets can schools leverage in the process of doing equally safe? And then, yeah, we also want to look at follow-up over 2 years and re-examine our theory of change. This is what the design looks like. So when a school decides to join the study, they first do the baseline student survey. They're then recruited. Stratified randomization. So they're stratified according to whether they're doing mentors in violence prevention, which is the other big intervention being rolled out in Scottish schools. The proportion of students on free school meals, which is an indication of the sort of deprivation area of the school, and the school size. So if they get randomized to group 1, they start equally safe straight away. We follow them up over 2 years of implementation with student surveys annually. And we will have 6 case study schools where we'll be looking in depth for the process evaluation. If they're randomized into group 2, we ask them to hang fire for a year, and then we will follow them up for 1 year of doing the equally safe activity. So it's a kind of lagged design, and in some of our analysis, we're using it as a sort of stepped, wedged design. I won't go into the analysis, but we're doing a range of different analyses, which involve nested cohorts of following up students, longer term change, because it takes time for change to embed in an intervention like this, and an economic evaluation. We've got 34 schools recruited, 26 have undertaken the baseline survey, 23 have been randomized, and 13 have begun the equally safe intervention. Anyone here who works in schools will know the challenges. It's all around the school timetable. You can't have delays. We're obviously coming to a wall at the end of March, and then they'll be going off for exam leave, so we won't be able to do any more baseline surveys. But we have been able to meet our recruitment target for the year, which has felt like a massive relief. So thank you. It's a huge team, a huge effort, and it's a great team as well. Really enjoying working with you all. Some of you are here. And thank you. And any questions?
One quick question while I load the next presentation.
Put my glasses on so I can actually see it. Hi.
It's really, really interesting. Just from general practice. So I suppose I'm just thinking about, even about your stratification. I just wondering, it's maybe too early to pick up, but I suppose what I'm thinking about it from a health point of view is the sort of cohort of young people that be in schools who sexual harassment is like the sort of one element if you're actually in the background a lot more going on in terms of witnessing domestic abuse at home. Is that something that I would imagine that that's maybe one of the concerns that teachers will have?
Yeah. So, well, I mean, it's a whole school approach. It's really about changing the awareness and the school culture. So, a key thing is trying to prevent what's going on, to address what's happening in schools and call out things that are being passed off as banter. But yes, I mean, there are individual students. So I guess that's to say it's a kind of community level safeguarding. And so by increasing the general attitudes that students have, you are you're safeguarding the group. But what we would also hope was that, so those students often who are vulnerable or have things going on at home are often known to the guidance teams of schools. But it may help them support those students more by just having a better awareness of the ways that these kind of attitudes can play into things that are going on at home, or by strengthening the school's relationships with third sector organisations that they may be working with for liaising for more support. So it's really, more at that level. Yeah.
Just quickly, there's a question in the chat online. Did you link in with MVP Mentors in Violence program, which is a GBV program already in some secondary schools?
I can answer that quickly. Yes, yes, very much so. The leads of and these are the two key initiatives going on in Scotland, and they're very much working together and seeing the two as complementary.
Okay, lastly, we have Daniel to talk to us about taxation, social security policies, and psychological distress.
Okay, thank you. So I'm going to talk here about how we can fill evidence gap and an evidence need in policy making. And what we know is that the individual economic circumstances of people influence their health. We know that income influences health, that employment influences health, exposure to poverty, but we don't necessarily know how to utilise these pathways using tax and benefit policies to improve population health. And the reason why there's often this lack of actionable evidence on utilising these pathways is often it can be quite unethical to run randomised controlled trials when you have one group that get a benefit and one group don't. And then the other issue is that it can take a very long time for these health benefits to emerge, possibly a decade or more. So it's very difficult to actually have real world evidence to support these policies. But what you can do is that you can use microsimulation modelling to start to extrapolate beyond observed data and look at hypothetical policy scenarios. So that's what we're going to do here. And the thing that we are evaluating is the policy response to a particular economic crisis. So that was the economic crisis that resulted from the COVID pandemic in the UK. And what we are able to do with microsimulation is we can look at the policies that were introduced and have a sort of projections for them, and we can compare these to a counterfactual scenario. If these policies hadn't been introduced, what would have happened? So it's a series of prediction processes that go on here. So I'm sure you all remember that it was quite the economic crisis when the pandemic hit. We had a very large contraction in output and a very strong discretionary response from the government. And a lot of these experiences were at the individual level or the household level. So people lost their job, the household income fell, those sorts of things. So it's ideal for microsimulation. But also what's really great about, well, what's really useful about this particular economic crisis is that there was a novel policy response. So things happened that hadn't happened before during economic crises in the UK, in particular the furlough scheme. So protecting people's employment temporarily whilst the crisis was at its worst points. But also there was this temporary uplift in social security, and there were some other policies that came in around this time. So it was an interesting policy response. So the microsimulation framework that we developed along with colleagues at the University of Essex is called SimPaths. So this is an open source microsimulation model going across various domains. Here we're looking at a relatively short period of around 5 years, but we have ambitions to start to look over much longer periods. So to understand what it is for some of you, this is you transition the individuals from one state to another based upon a series of prediction processes. So these prediction processes are often regression models, just simple regression models using observed data outside of the model, and then we bring them into the model, and it's the layers of these predictions that bring it all together. We have many modules, so many different elements of someone's characteristics, and you can pick and choose these as you want if you ever choose to use SimPaths. And we have the dynamic elements and that things are happening over time. We have behavioural responses, so people make choices within the model, particularly about how much labour they're going to supply. So that creates this link between the policies that are brought in and the employment response of the individuals or the households, which then links to their health outcomes. So you have these behavioural elements and also spatial elements. We can do this across, at the moment, government office regions. But if we had data at smaller, at more disaggregated levels, we could do that also. Yeah, we have this integration with another simulation model that tells us what the income change would be for that individual under a series of policies. And then, of course, we can make this model, but we have to find out if it's useful or not. So the way that we do that is that we simulate the past. So we simulated the period between 2011 and 2019, and we look at how our predictions compared to the observed data, and everything was okay, so we went ahead. So this is what the model looks like, and as I said before, these are mainly, I mean, aging. That's a very simple prediction process. Every year you get a year older, but the other ones are a little more tricky. But again, they're just the output of regression models. So although it might look complicated, and a few of them, there's a bit of matching that goes on that is a little more complex, but there's nothing here that is particularly new. It's the way in which it's combined that's quite innovative. And for our purpose, it's the labour supply module down the bottom. As I said before, this creates that behavioural link between the policy and the outcome. And then in the top left, the mental health outcomes, which is what we focus on initially. Oh, and yeah, the data that starts, the data that goes in at the beginning is observed data from the Understanding Society survey. So nationally representative household panel. So this, again, to get the idea of what the micro simulation is doing, it's taking that observed data and just extrapolating into the future to create projections. Okay, so these are some of the coefficients. So for the link between the economic outcomes and the health outcomes, we try to do a little bit more to parameterize the model. So we try to use some causal methods here. And the point of this slide really is to show that the effects of employment, so these are the effects beyond the change in income, are extremely important to the outcomes in the model. So we have here employment, we have income, and we have poverty. And by the size of the coefficients, you can just see just how important employment is to the health outcomes within this simulation. This is one of the graphs, so I said about we validated against the period 2011 to 2019. The red line is what is observed, and then the grey area is what the model predicts. So, there's a significant overlap in all of these, and there's also room for improvement. We're still constantly refining the model. Now, I'm sure some of you are already thinking this is prediction upon prediction. It's going to be quite unstable. So we try and bring in that uncertainty. We try and actually quantify that uncertainty within our estimates. So every time that we run the model, every cycle of the model, the parameters that are within the model are selected from the confidence intervals for those regression models. So in effect, what you have is in each cycle of the model, the coefficients are quite different, but they're centered around the point estimates of the regressions. So it's just to try and get some of that uncertainty that you're getting from these layers of prediction. And then we run the simulation 1,000 times and report uncertainty intervals. So some results. So these are the results from the economic pathways. On the left, you have the employment rate, and on the right, you have the poverty rate. The grey lines are with the COVID policies. So this is the observed policy response. And the black line is the hypothetical policy scenario where there was no response to the economic crisis. Now, that is actually what usually happens during other economic crises. So this is why the COVID one was unusual. And we have another coefficient in there to take away the non-economic effects of the pandemic. So that's in both arms. So what you see anyway is that there would have been a very significant drop in the employment rate if there hadn't been the furlough scheme to a large extent. So exactly what you would expect. although once the economy recovers towards 2022, there's quite a rapid recovery in the employment rate, but still this difference remains even beyond that time. And with the poverty rate, something similar, in that there was a very large uptick in the poverty rate if there hadn't been the policies to support employment or the extra benefits that were on offer. But this also has a lasting effect on the poverty rate. That's what we estimate from this model. This converts into quite a small, relatively small effect in terms of the impact on mental health. So on the left, you have the just the score on a mental health measure, the 12-item general health questionnaire, and then on the right, you have the prevalence of common mental disorders. So you again see a similar pattern that when the crisis starts, there's an uptick in both arms, and this is slightly less because of the policy response, and it's the same for the common mental disorders. So one part here is that the point estimate, the median estimates, they are obviously different, and you have the kind of outcomes that you would have expected. But because of the amount of uncertainty that we build into the model, you have quite large uncertainty intervals. But if you start to look at the difference between paired runs, this is using the same random seed within each run. So it means the same set of coefficients. So these are comparable in every way, except that one has one policy scenario and the other has a different one. And you can see there that it's much more obvious that there's a difference in the prevalence of common mental disorders, and that the policy response has a preventative effect, particularly in 2020, but also in 2021. So just to conclude, the policy response did seem to be effective in the short term in terms of mental health, and also had some lasting impact, particularly on poverty. So although that was quite a small looking difference in the graphs, this is 1.2 million cases of common mental disorders that were estimated to have been prevented in 2020. And when you start turning these into quality adjusted life year values, this is a very substantial economic benefit of 11.3 million just from the health effect. That doesn't include the indirect effects of maintaining employment and so on. So with this model, we think we have shown that social security policies can provide substantial health benefits during periods of economic crises, and this could also be applied in the future. And also that microsimulation can overcome some of the barriers that limit the evidence base for policies that utilise the pathways between income and employment and health. Yeah, a lot of co-authors and a lot of funders. It's been about 3 years of work to get to this point, and we have a lot more plans. Okay, thank you.
It is one, so if you need to leave, that's fine. But if you have questions for Daniel, they'd be very welcome.
There's a question in the chat I can read out. So were you able to compare outcomes for legacy benefit recipients who didn't get the benefits uplift with universal credit recipients who didn't receive the uplift?
So we didn't do that in this project, but we have another project that's ongoing, which is an evaluation of universal credit, which does this comparison with legacy benefits. So, and that's using the same microsimulation framework. So the SIMPATH framework is going to be used across multiple models, one of which is a evaluation of universal credit. So that will come in the future.
Oh. Another question? Sorry.
I can see Nicola Burns has got her hand up online. Nicola, did you want to ask a question?
Yeah, if that's okay. Thanks, Daniel, for a fascinating talk. I guess one of the things that really piqued my interest was the notion of policy that was being used in the study. I guess I was wondering, how are you seeing policy? You know, I guess thinking back to my presentation, that the policy is power. And actually, like how you understand policy, I guess, also frames some of the questions that you were asking. So I guess I was just wondering about that.
So here we view them as a set of rules that apply to certain individuals in quite consistent ways. So we have this static tax benefit microstimulation. So for that, we have to tell it what the rules are. That's the way this works. So yeah, we're viewing policy as a set of rules.
Okay. I'd also just to say I was part of a team that were looking at the impact of COVID on individuals, including people who experienced mental distress, ongoing mental distress before the pandemic, and I think actually your point around the sort of preventive nature of social security benefits was absolutely, it was something that was very much raised with from the participants who kindly gave their time at such a stressful moment for all of us. I guess one of the things that's fascinating for me is you're saying there about a universal credit, and we know that, you know, the impact of social security policy changes is profound for people. You know, we've got increasing inequality, etc., and the impact on people with ongoing mental distress is profound, really. And I guess I'm interested in what's the sort of outcome, or what sort of, how are you sort of pushing that back to policymakers in a way?
Yeah, okay, so
Hello?
Oh, did we just lose them completely?
Yes, it seems that way.
Hang on, let's see if we can get Carolyn back. Oh.
I didn't realise my question was that awful.
It might be that it's ended automatically because we're a bit over time.
Oh, maybe. Hi, Yvonne. Lovely to see you in your cheery jacket.
So can I suggest yeah, maybe following that up with
Yeah, I mean, it's
so sorry about that, Nicola. I got cut off short. But it looks like people are dropping off now anyway, so I think perhaps there's not time to finish that one off. But yeah, please do follow up with that question. That sounded like it was going to be an interesting discussion about to happen. Thanks, everyone. See you.
Okay. Bye.
Cheers, bye.